It's been quite a while, so I thought I would actually do you guys a video. So grab your piece of paper and let's talk about scabies. Let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Mosesjrk. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at scabies. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment to Zombie and Beyond, grab your piece of paper, and let's go. Scabies is actually an infestation that's going to be caused by a mite by the name of Scabie. The variant is hominis. And remember that this mite is an obligate human parasite that's going to be living in these barrels that are going to be formed in the skin. They're like tunnels that are going to be formed in the stratum corneum. The transmission of this is roughly through person-to-person contact, through physical contact, but we have seen some transmission that may probably occur with animal as well as fomites. And contrary to popular belief that scabies actually the primary risk factor is poor hygiene, research has actually shown that there is no clear association with poor hygiene and scabies. We have the primary risk factor being overcrowding that is seen in schools, shelters, barracks, and even some different households. Other risk factors include immunosuppression, in our setting HIV and AIDS being the most common cause of immunosuppression. Then you may also have certain other drugs like chronic use of corticosteroids, immunosuppressant, and then of course you may have hematological cancers. Now remember that the type of scabies that we often see in these patients is what is referred to as crusted scabies. We'll talk about it in much more detail much later on. Then you may also have patients with severe physical disability. You have those that have intellectual disability. These are going to be also having crusted type of scabies. You may have Australian Aborigines, which are also going to be having crusted scabies, and those that are living in a warm climate. These tend to develop these small reddish papules and a few of these barrels. And remember that it's not really the geography that actually predisposes you to scabies or the severity of scabies, but rather the level of your immune system. The stronger immune system, the less severe it's going to be. The weaker immune system, the more severe it's going to be. And remember that this can affect any different part of the body. And what we actually see is that you get these mites actually infesting into the skin. Then of course they're going to be digging and forming these barrels, and then eventually they're going to be laying eggs in these barrels. Then these eggs are going to hatch off and give offspring that are going to be crawling out of the skin and then making new barrels, and this continues on, and the infestation goes on. And sometimes you may have the excrement of these mites, quote unquote, the poop of this mites that actually gets to sip into the skin capillaries, and this can actually generate the hypersensitivity reaction. So this is a type 4 hypersensitivity reaction, or a delayed type of hypersensitivity reaction. Now let's talk a little bit about the clinical features. Remember that the incubation period is roughly between 4 to 6 weeks. That's roughly a month. And the primary symptom that you're going to be getting is this intense itching, this generalized itching. And what's characteristic about this is going to be it's worse at night. But of course, this is not just specific to scabies. You have different types of presentations that may depend on the different types of scabies, such as classic scabies, which I'll talk about in detail, crusted scabies, which is also referred to as Norwegian scabies, nodular scabies, bulla scabies, scalp scabies, as well as scabies incognito. The last three I won't go into so much details of because they're not so very common, but the first three I will go into a lot of detail into. So we'll begin with classic scabies, which is the characteristic thing that, or the typical thing that patients usually present with. So here they're going to be presenting with these reddish papules. I actually discussed a lot of these dermatological terms in a video that I'll leave tagged. Just click here and you may actually go and watch the video. I'll also leave it tagged at the end of this video so that you can actually watch the dermatological terms and understand what a papule is. So you have these reddish papules that are going to be initially appearing in what I like to call the hidden spaces. So they're going to be found in, of course, the interdigital folds. They're going to be found in the wrist, the elbows, the umbilical area, the genital area, and the feet. They may be found in the finger web spaces, the flexor surfaces of the wrist, the elbow, the axillary folds, the belt line, and even on the lower buttock. And remember that these papules can affect any area of the body, including the breasts and the penis, and of course the face remains uninvolved in adults. So what you get to see is you get to see these barrels, which are usually present on the wrist, they're present on the hands, and they're present on the feet. And once you see these barrels, you pretty much have a diagnosis of scabies because they are pathognomic. How do we describe them? You get these fine wavy, like even slightly scaly lines that are about like 1 centimeter long, and you can quote unquote call them silvery lines, and they have this tiny dark papule at the end, which is referred to as the mite. So this may sometimes be visible. So in this type of classic scabies, people are usually going to be having about 10 to 12 mites. Now, secondary bacterial infection is very common. Remember that I say this is very itchy. So you can often get the child scratching the hell out of the skin. And of course, it causes some abrasions. It causes some opening of the skin. Staphylococcus that lives on the skin can actually infect these openings and actually it can actually have a staphylococcal skin infection. Then, of course, the signs of classic scabies may be atypical, especially in black people or people that are of dark skin. So you get this manifestation of these granulomatous nodules. In infants, you may get these nodules on the palms, the soles, the face, and the scalp. And then, of course, they may be in the posterior auricular fold. And in the older patients, scabies can actually cause intense pruritus with subtle skin findings, and this actually makes the diagnosis very, very difficult for us to make. And in those that have immunocompromised, those that are immunosuppressed, there is this widespread non-pruritic scaling. Remember, this is going to be particularly very common in the palms of the hands and the soles of the feet in adults, and very common in the scalp. So sometimes you may actually even confuse this with syphilis. So here is the picture. As you can see, you have these silvery lines that you can actually pick up on in between the digits, and you have this as the hallmark of scabies with these dark mites at the end of these silvery lines. And then on the other image on the right here, you have these erythematous papules. As you can see, this erythematous papules that are present on the palmar area of this hand. Then here you have infantile scabies, where you have these pustules that are seen on the soles of the feet. As you can see, that you have these pustules on the soles of the feet. You can also see them on the palms of the hands, though not depicted in this picture. Now, you may also have crusted scabies. This is what we often see in patients that have an impaired immune response. So remember that the mites are going to be allowed to proliferate because the immune system is not there to keep them in check. So you may actually get an individual having millions of them. Remember, in the classic scabies, we only had about 10 to 12 of them, but here we can actually have millions of them. And this is also seen in young infants. So you get the scaling erythematous patches that often involve the hands, the feet, the scalp, but can also be widespread. So the infestation actually results in hyperkeratotic and all crusted generalized rash. As we can see here, this is a child that has some scaling and hyperkeratotic plaques in an HIV patient with crusted scabies. Then you may also have nodular scabies, which is very common in infants and young children. This one is due to the hypersensitivity to retained organisms. Now you get these nodules. As you can see, you have these characteristic brownish red papules that are found often in the groin. They may be seen in the genitals, they may be seen in the scrotum, the axillary folds, the back, the feet, and the buttocks, and usually they are about 5 to 6 centimeters. Now remember that these nodules are pretty much hypersensitivity reactions, and they may sometimes even last for months. This is a very important thing to know because you may get the itch lasting months and you think that this patient was poorly treated or they've had a reinfection. Meanwhile, it's just something that was already completely treated. It's just residual symptoms that have remained despite the mites actually dying. Then you may have other forms of scabies such as bullous scabies, which occurs more commonly in children. So this one is very difficult to actually distinguish from bullous pemphigoid, so this can actually delay the diagnosis. You may have scalp scabies, common in immunocompromised patients as well as infants, but this can mimic other types of dermatitis such as atopic dermatitis as well as seborrheic dermatitis. Then of course, scabies incognito is this widespread atypical form, which is commonly seen in patients that have chronic use of corticosteroids, of course topical use of corticosteroids. Now, how do you make a diagnosis? So there are two important things that you you really need to note. So your clinical evaluation is very important. So under your clinical evaluation, you're going to want to identify the lesions. So under your physical examination, you're going to want to see the barrels. There's going to be a history of itching in your history when you take a history from your patients, and you also have this background of patients that are at home having similar symptoms to your patient at the hospital. Then of course, imaging and magnification of the skin using a handheld instrument, that's a demoscope, can be done to identify the scabies. Then of course, once you have identified them, you have to actually get scrapings of the barrel to actually visualize them under the microscope. And if you see the mites, you see the ova, you see the fecal pellets, which is the poop, this is what you actually use to make a diagnosis of scabies. But sometimes you may not find the mites, you may not find anything. So this is actually doesn't exclude the diagnosis. It doesn't mean that the patient doesn't have scabies. You should always use your clinical acumen. So the scrapings are often going to be placed in glycerol, mineral oil, or immersion oil over when you're doing the scrapings, you place this oil over the barrel. The reason why you're doing this is you want to prevent spread of this material as you're scraping the skin to the other areas of the skin and spreading the infestation to other areas of the skin. Then of course the material is going to be placed on a slide, and then the cover slip is going to be placed, and you should not use potassium hydroxide because it's going to dissolve the fecal pellets. Then what's the management? So we divide the management in largely two parts. We have what we call the general advice and what we refer to as the medical treatment. So I'll begin with the general advice. So the first and most important thing is, of course, to educate your parents on this condition. You give them clear written instructions, because each and every single type of cream that we're going to be talking about are going to be having different instructions. So that's the first thing. Make sure that you explain the instructions very well. The second thing is that if you get a patient that has scabies, you ensure that everyone at home must receive the treatment. Everyone at home, as well as the close contact. You must also deal with the personal items, things like towels, clothing, beddings. These must be washed in hot water, and by hot water meaning it should be above 60 degrees. If you can't wash them, you can actually dry clean them. And then of course, if you can't dry clean them or wash them, you can actually put them in a sealed plastic bag and keep them there for 3 days. The essence behind this is you want to get rid of the mites, you want to get rid of anything that can reinfect this person. And remember that only allow the patient to go back to school 24 hours after them starting the treatment. So you shouldn't go to school because it can actually spread the infestations to others. And like I said earlier on, you may have this pruritus that may actually persist 3 weeks after the treatment, even if all the mites are dead. And actually, this is not an indication that you must retreat the patient. You must take this with caution. The pruritus can actually be handled with diphenhydramine or any other antihistamine that is present on the market that is indicated for the particular age group. You may also get common superadded bacterial infection because of this child scratching all the time, and you should treat these as you treat any other superadded bacterial skin infection. Remember, staph is a very common thing. Now, when it comes to the medical treatment, the primary treatment is, of course, topical or oral scabicides. We want to start with the topical ones, with, of course, our drug of choice being permethrin. So permethrin 5% actually can be used even in infants that are as young as 2 months going further. For the older children and adults, they should apply permethrin to the entire body from the neck downwards, and of course wash it off after 12 to 14 hours, although some literature actually cite that you can actually wash it out even after 8 hours. Then we want to prefer permethrin over another cream which is known as lindane. The reason why we don't use lindane, especially in children, and to be specific, children that are less than the age of 2 years and children that have seizure disorders, is because it's neurotoxic, so it can actually exacerbate seizures. The treatment of permethrin cream application must be repeated after 7 days, and although some patients can actually have a single application and it actually works, but most patients actually you should apply it twice with a week in between, and then of course reassess this patient. And then for the infants and the young children, the permethrin cream should be actually applied to the head and the neck, avoiding the periorbital and the perioral regions. And of course, you should also target the areas, the hidden areas. That's the intertriginous areas, the axillary folds, the in between the buttocks, the fingernails, the toenails, and the umbilicus. And of course, we apply it on the hands if it has been washed off by soapy water within 8 hours of application. Then of course, you should put some mittens on infants that can keep the permethrin out of the mouth of the infant, because they eat just about anything. And of course, the itch may actually continue 4 to 6 weeks post-treatment, like I said, so you do not have to treat them again. The child should avoid school until the first treatment is actually complete, until they've actually had this cream on them for at least 12 hours. Then of course, you may use benzyl benzoate, which is EBB. You use about 12.5% emulsion in children that are aged between 7 to 12 and 25% in those that are above the age of 12. We want to apply this every night or every other night for a total of 3 applications. And of course, it can irritate the skin and the eyes, and it can also cause seizures when it's ingested. So we want to avoid this, especially in children below the age of 7. We want to avoid this in children that actually have epilepsy or any other seizure disorder. Then for the adults and the children that are 4 years and older, we can use spinosad 0.9 topical suspension, which can be used to actually apply to the entire surface of the skin from the neck going downwards. You should also apply to the soles of the feet and the palms of the hands. Of course, in both patients, you can actually even apply to the scalp, to the forehead, the hairline, and even the temples. Remember that this suspension should be allowed to dry for 10 minutes before you actually get dressed, and then you should leave it on the skin for at least 6 hours before washing it off. The treatment is also just like with permethrin cream, should be repeated after 1 week. We may also have crotamyton, which is Urax. We apply 10% of this cream to the entire body from the neck downwards for 2 nights, and then of course we wash it off 24 hours later, and then after the second application. Remember, we can use either one of these creams based on the availability, so usually our drug of choice is going to be our permethrin cream. And of course, you may have precipitated sulfur 6 to 10% in petrolatum applied for 24 hours. We do this for 3 consecutive days. This is actually safe, it's quite effective, and we can actually even use it in infants that are less than 2 months, because remember, permethrin cream is not indicated for infants less than 2 months. Then we may also give oral medication, especially for those that have Norwegian scabies, those that are immunocompromised, and those that are not able to adhere to these topical regimens because they have to be done strictly for a certain number of hours. So you can actually give them ivermectin. If they don't respond to the topical treatment, this is another indication which we can give them ivermectin. We may give them also some corticosteroid ointments and even antihistamines to help with the itching. And of course, secondary infections should be considered if the patient has these weeping sores, if they have these yellow crusted lesions, and they should be treated with systemic and topical antistaphylococcal as well as antistreptococcal antibiotics. Remember that symptoms and the lesions take up to 3 weeks to resolve, despite you killing off the mites, like I said. So this makes it very difficult for us to make a diagnosis of treatment failure due to resistance. It makes us unable to know whether there was poor penetration, if the patient incompletely applied the therapy, or if there's reinfection or there's nodular scabies. It's very difficult to differentiate between these 3 scenarios because you get this pre-test that is lasting up to 3 weeks. But of course, we can do the skin scrapings periodically to check if there is persistent scabies. I really hope you have learned a lot from this video. If you did, consider subscribing to the channel. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.